Now, very importantly, let us see now how the insulin release occurs. All this you have already know. Okay, all this you already know now. So basically, whenever the blood glucose level increases in our body, so what is going to happen? Okay, that blood glucose is going to go. What is this that we are looking at? We are looking at a pancreatic beta cell. So whenever the blood glucose levels will increase, they are going to go inside the pancreatic beta cell by means of a transporter called as GLUT2 transporter, which is an insulin independent transporter. It doesn't require insulin for its function. So this glucose now enters the pancreatic beta cell. Inside the pancreatic beta cell, they will undergo metabolism inside the mitochondria, and via the oxidative phosphorylation, the ATP will be generated. Once this ATP is generated, okay, this ATP is going to inactivate this ATP sensitive potassium channel. So this ATP that is formed because of this glucose is going to inactivate the potassium channel. And once the potassium channel is inactivated, it leads to membrane depolarization. That is, there will be excitation leading to an influx of calcium within the beta cells of the pancreas. Okay, this influx of calcium stimulates the release of insulin. Okay, now remember, insulin is released in two important steps. The first step, there is an immediate insulin release. So whatever insulin was there preformed in the preformed granules, they are released. That is the first phase of release. Now, suppose the level of glucose still remains high. If there is a persistent stimulus, this is going to stimulate the active synthesis of insulin. That is, the second phase of insulin secretion is going to start. So good evening, everyone. Today we are going to start with diabetes mellitus, and today we are going to read part 1 of diabetes mellitus. So first we have to understand certain basic aspects, then only we will be able to understand diabetes mellitus in details. So very importantly, the endocrine pancreas. Okay, the pancreas has two parts. One is the exocrine part, one is the endocrine part. So today what we are going to read, it mainly deals with the endocrine pancreas. So the endocrine pancreas, they are having 4 main type of cells and they have 2 minor cells. So if you see the 4 main type of cells which is present in the pancreas, that is the beta cells which secretes insulin, whose main function is to reduce the blood sugar levels. Similarly, we have the alpha cells which releases glucagon, whose function is just opposite to insulin and it increases the blood sugar level. We have the delta cells which secretes somatostatin, which basically inhibits the insulin and also stimulates glucagon release. Okay, then we have pancreatic polypeptide cells called as the PP cells, which is secreting the pancreatic polypeptide. So what is the function of the pancreatic polypeptide? Basically, they have an effect on the gastrointestinal tract. So they increase the gastric and intestinal enzyme secretion, and they also inhibit intestinal motility. So these are the 2 important functions of the PP cells. Okay, so the 4 main types of cells in the endocrine pancreas are the beta cells, alpha cells, delta cells, and PP cells, which is secreting insulin, glucagon, somatostatin, and pancreatic polypeptide respectively. Okay, now there are 2 minor cells that we can appreciate in the endocrine pancreas. If you see, there are 2 minor cells. So what are these 2 minor cells? These are the D1 cell, which is responsible for secretion of vasoactive intestinal peptide, also called as the VIP. And what is the function of the vasoactive intestinal peptide? They stimulate glycogenolysis, that is the breakdown of glycogen, releasing the glucose into the circulation, thus increasing the blood sugar level. They are also stimulating the GIT, the gastrointestinal tract, okay, and they stimulate the fluid secretion as well as they are going to stimulate the diarrhea as well. Okay, clear to everyone? Okay. Now, the second major minor cell that we see over here, the second minor cell is the enterochromaffin cell, whose function is to secrete serotonin. Now, any kind of pancreatic tumor involving these cells, basically the enterochromaffin cells, leads to the secretion and effects of serotonin and leads to classically what is called as carcinoid syndrome. So with this, I hope you have understood all the basic aspects of the different kinds of cells that we see in the endocrine pancreas. Okay. So this is the diagram for the same. There is a classical immunoperoxidase staining showing the hormone production in the pancreatic islet cells. So you can see in the pancreatic islet that the beta cells are predominant and they're secreting insulin. The alpha cells are secreting glucagon and the delta cells which are secreting somatostatin, as we can appreciate over here. Now, very, very important. Now we are going to start the today's topic of discussion, that is diabetes mellitus. Now, if you remember, diabetes mellitus is also called as the silent killer. It is very much prevalent in our society. Every third person is suffering from diabetes mellitus, and yet we know very little about it. So this is an area of active research, and a lot of treatment is now available for diabetes mellitus to reverse the process. And it is a very complex multifactorial disorder wherein not a single factor, but a complex number of factors together, they come into play to cause diabetes mellitus. So what is diabetes mellitus? If you look at the definition, it is a group of metabolic disorder sharing common feature of hyperglycemia caused by defects in either insulin secretion, or if the secretion is normal, then there is some defect in the insulin action, or both. Both the secretion and the action is affected. Now, it is the leading cause of end-stage renal disease. It is a leading cause of end-stage renal disease as well as adult onset blindness, and a cause of non-traumatic lower extremity amputation. So every other cause of amputation that you see in the hospital, which is non-traumatic, you are going to see that diabetic foot accounts for a maximum number of cases. The normal blood glucose in our levels is around 70 to 120 milligrams per deciliter. This range has been given by the WHO and the American Diabetic Association, that is the ADA. Now, very important thing that we have to understand, we should know very precisely that what is the diagnostic criteria of diabetes mellitus. So when can we say that the person is diabetic? So either the fasting plasma glucose level is more than equal to 126 milligram per deciliter, or the random plasma glucose level should be more than equal to 200 milligrams per deciliter in a patient with classical sign symptoms of diabetes. Okay, what is the classical sign symptom of diabetes mellitus? Yes, triple P, polyuria, polydipsia, polyphagia. So patient presenting with the classical sign symptoms of diabetes mellitus and with a random plasma glucose level of more than equal to 200 milligram per deciliter basically will constitute a diagnosis of diabetes mellitus. Or if we carry out a 2-hour plasma or a 2-hour plasma glucose level more than 200 milligram per deciliter during an oral glucose tolerance test called as OGTT, okay, with a loading dose of 75 milligrams of glucose. Okay, so the patient is given 75 milligram of glucose in a glass of water, and after 2 hours, the patient's blood glucose is recorded. In that, if it is more than 200 milligram per deciliter, it is again a case of diabetes mellitus. And very importantly, nowadays they are using sophisticated parameters like glycated hemoglobin levels called as HbA1c levels more than equal to 6.5. I hope all of you know what glycated hemoglobin is, because the same has been taught to you in biochemistry. So these are the 4 important. Either of them, if it comes out to be positive, okay, they will be regarded as positive for diabetes mellitus. Now, very important thing, all of these tests 1, 2, 3, 4, except the test number 2, okay, all the remaining tests, okay, this test, and this, so 1, 3 and 4, these 3 tests, they need to be confirmed on a separate day so as to confirm the diagnosis of diabetes mellitus. Whereas the test number 2, in the presence of sign symptoms of diabetes mellitus, if the random plasma glucose is more than equal to 200, then this need not be repeated. Okay, it is confirmatory on the first test itself. Whereas the test number 1, 3 and 4 have to be repeated and confirmed on a separate day. So why is it so? That why it is happening like this? Acha, one more thing. If, for example, you are doing 2 tests, for example, you did the test number 1, this is the test that you did, the test number 1, fasting plasma glucose, and you did the glycated hemoglobin level. Now, out of these 2, which one should be accepted? For example, the fasting plasma glucose level came to be around 120 or 122, whereas the glycated hemoglobin level came out to be, for example, 6.7. So the test which is having maximum abnormality has to be accepted. So whichever test will have maximum abnormality, that will be accepted as the we have to choose that for diagnosing the patient. So the one which is having the greater degree of abnormality should be chosen. Now, very important, whenever you are assessing a patient of diabetes mellitus, you have to rule out any kind of acute stress like burns, infection, or trauma. Why? Because any kind of acute stress, okay, whether it be emotional, physical, so they tend to increase the blood sugar levels because of the action of catecholamines, the stress hormone that we know. Okay. So basically remember, the catecholamines which is released in the acute situation, they tend to inhibit the activity of insulin. Okay, so as a result, in any acute situation, we should not diagnose the case. So the diagnosis of diabetes will require persistence of hyperglycemia following the resolution of INSULIN. So after the acute episode is over, after that, again, I have to check the blood sugar levels and I have to carry out a different confirmatory test so as to confirm. So remember, the test for diabetes mellitus is never done, or the diagnosis is never made during the periods of acute stress. Is this very clear? So you should be thorough with the diagnostic criteria for diabetes mellitus. Now, secondly, very important thing over here is the pre-diabetes. So what do you mean by pre-diabetes? What is pre-diabetes? It is a state of dysglycemia. Dysglycemia means an abnormal level of glucose that often precedes the development of frank diabetes mellitus. That is often going to precede the development of frank diabetes mellitus. So it is often very necessary to recognize these individuals who are pre-diabetics, because we can give certain lifestyle changes to such individuals. So what is the criteria for diagnosis of pre-diabetes? If the fasting plasma glucose level, if the fasting plasma glucose level is between 100 to 125 milligrams per deciliter, okay, that is an impaired fasting glucose. If the 2-hour plasma glucose lies between 140 to 199 milligrams per deciliter following a 75-gram oral glucose tolerance test, we call it as an impaired glucose tolerance test. And or if the glycated hemoglobin or the HbA1c level is between 5.7 and 6.4%, then also we are calling it as a pre-diabetes or impaired glucose tolerance. So it's very, very important to know these criteria, which are the diagnostic criteria for diagnosis of diabetes mellitus, and which are the criteria for the diagnosis of pre-diabetes. Okay. Remember, 5 to 10% patients, just remember, patients having impaired glucose tolerance or impaired diabetes, okay, they have a 5 to 10% risk per year for progressing to diabetes mellitus. So it is very important to recognize these patients. And nonetheless, just like patients of diabetes mellitus, they are also at an increased risk for cardiovascular disease. Okay. So now it is very, very, very much clear, very easy, clear what are the points required for diagnosis of diabetes mellitus. And it is also very clear that what are the points required for diagnosis of pre-diabetes mellitus. Yes, very clear to everyone. Now we are going to see the classification of diabetes mellitus. Now remember, now in this age, if you just say type 1 diabetes mellitus and type 2 diabetes mellitus, you are not going to get full marks. When they ask you about the classification of diabetes mellitus, which they will, in all the questions, this is the component of the answer. Okay, so the classification of diabetes mellitus, there are 11 types, and usually the classification carries approximately 3 to 5 marks. So what happens that in the exam, whenever the exam is being conducted, what happens that you tend to leave the classification. So it is very important for you to know the different kinds and the classification of diabetes mellitus in details, because it carries good number of marks and MCQs. Okay, an area which is neglected. So everyone knows that there are two major variety of diabetes. One is your type 1 diabetes mellitus, okay, which occurs because of beta cell destruction, okay, in the islets of pancreas, leading to an absolute insulin deficiency. Then we also have the type 2 diabetes mellitus, which is characterized by insulin resistance along with beta cell dysfunction. Okay, so we will read in details about the pathogenesis of type 1 and type 2 diabetes mellitus. Okay, the third important class of diabetes mellitus is those which is associated with genetic defects in the beta cell function. Among them, the first group of disorder is maturity onset diabetes of the young. Okay, very, very important, very, very hot question. Modi can come just as a small short note as well. So this maturity onset diabetes of the young, it occurs because of mutation in several genes, and depending on whichever genes are involved, okay, there are different types of MODI. So what are the different types? There are approximately 6 different types of MODI that is there. So if the mutation is there in the hepatocyte nuclear factor 4 alpha, that is HNF4 alpha, we call it as MODI 1. If it is involving the genes encoding glucokinase, it is called as MODI 2. Again, if it is having to deal with the mutation in the HNF1 alpha, it is MODI 3. In the pancreatic and duodenal homeobox or PDX1, it is MODI 4. HNF1 beta, it will become MODI 5, and Neuro D1, it will become MODI 6. Okay, so this is the classification of the MODI, which comes under the genetic defects of beta cell function. Now, secondly, under the genetics, we have the neonatal diabetes, which is characterized by activating mutation in KCNJ11 and ABCC8. Now, KCNJ11, it is synthesizing a protein that is KER6.2, and ABCC8 is synthesizing a protein that is SER1. Then maternally inherited diabetes and deafness, it occurs because of mitochondrial DNA mutation, a defect in the pro-insulin conversion, because insulin is formed from pro-insulin to insulin. So if this conversion is defective, again, it can happen, or insulin gene mutations. So these are the 5 classes of mutations which is coming under the genetic defects of beta cell function. So this was the 3rd category under the classification of diabetes mellitus. The 4th important category, if you see, is deals with the gene defects in the insulin action. Okay, so over here, classically, there is insulin receptor mutations leading to type A insulin resistance and lipoatrophic diabetes. Fifthly, we have exocrine pancreatic defect or pancreatogenic or type 3C diabetes mellitus. So this is the pancreatogenic diabetes mellitus, which occurs secondary to chronic pancreatitis or pancreatectomy or any kind of pancreatic trauma, pancreatic cancer, cystic fibrosis, and hemochromatosis. Okay. Then we have endocrinopathies, which can also predispose to diabetes, like acromegaly, Cushing syndrome, hyperthyroidism, pheochromocytoma, and glucagonoma. Then certain infections can predispose, like cytomegalovirus, Coxsackie B virus, and congenital rubella. The 8th type is drug-induced diabetes mellitus, especially the steroids, the glucocorticoids, the thyroid hormone, thiazides, phenytoin, nicotinic acid, beta-adrenergic agonist like salbutamol that we use. Genetic syndrome associated with diabetes mellitus, very important. Most common one is Down syndrome, Klinefelter's, Turner's, and Prader-Willi syndrome. And lastly, we are having gestational diabetes mellitus. So when you are asked about the classification of diabetes mellitus, which you will be asked, all of you will be asked about this question, you have to lay down this 11 types of diabetes mellitus in detail. So this is the classification of diabetes mellitus, which carries usually 3 to 5 marks. Okay. After this, before I go into the details of this today's topic of discussion, let me just give you a brief differentiation between type 1 and type 2 diabetes mellitus. Okay, so that you understand. So the onset of type 1 diabetes mellitus, it occurs in childhood and adolescence. Okay, that is why previously it was called as juvenile onset diabetes mellitus. Okay, but very important thing that you have to understand, that previous term has now been removed and it is called as just type 1 diabetes mellitus, because it can be seen in any age, including late adulthood also. You can see type 1 diabetes mellitus, though it is not that much common. Similarly, the type 2 diabetes mellitus is more common in adults. Okay, and there is an increasing incidence now in childhood and adolescence. So it is seen, earlier it was believed that type 2 is only seen in adults. So it is not like that. Now the incidence have been seen in childhood and adolescence. Can anyone tell me why the incidence of diabetes mellitus has increased in childhood and adolescence now? What can be the reason? Yes, what can be the reason?
Sir, fooding habits.
Very good.
Fast foods.
Very good. Nowadays, what is happening, that the children, okay, they do not go out of their homes. They want to just sit inside their home. They want to have food. All their life is in their phone, their mobile phone. So as a result, because of this kind of livelihood that they are having, they are becoming obese. Okay, and they're having bad food habits. So because of that, the incidence of type 2 diabetes mellitus has now been seen in individuals between 20 to 30 years of age as well. Regarding the levels of insulin in the body, so in case of type 1 diabetes mellitus, there is a progressive decrease in the levels of insulin. Okay, whereas in type 2 diabetes mellitus, in the early cases, you will have an increased blood insulin levels. Okay, whereas in the later stages of the disease, the insulin levels will become normal or they become moderately decreased. Okay, there's a moderate decrease in insulin levels. Okay, why, can you tell me why there is an increased blood insulin level in case of type 2 diabetes mellitus? What is the reason? Yes.
Sir, because there is just resistance to
Very good. There is
insulin.
insulin resistance. I will tell you all thing in detail when I discuss the pathogenesis of type 2 diabetes mellitus. Don't worry. Okay. Also, the presence of autoantibodies. Now, remember one thing, that type 1 diabetes mellitus, okay, the major pathogenesis is autoimmune or autoimmunity. The body itself is destroying the pancreatic islet cells. Okay, so autoantibodies against the islet antigens are present. What antibodies are present, we will discuss in details when we read the pathogenesis. Whereas these autoantibodies are absent. So autoimmune pathogenesis is not there for type 2. Autoimmune etiology is only there in the pathogenesis of type 1 diabetes mellitus. So if you look at the genetics, okay, so they have some relation with the MHC or the HLA. Now, what is the MHC? If you have basically, if you have attended my previous lectures on the immune system in general pathology, you must have seen that the antigen presenting cells are presenting the antigens with the help of certain molecules called as the MHC. Okay, so there are two types. One is MHC class 1 and class 2. So without this MHC, you cannot present any antigen to this T cells or the B cells. Okay, very important, remember. So over here, MHC is not in the question. But the thing is, there are certain mutations which are seen along this MHC gene. Now, MHC is called as the major histocompatibility complex, and in human beings, we call it as HLA or human leukocyte antigen. So basically, under the genetics over here, the class 2 HLA or MHC class 2 gene plays a role. So mutations in and around this genetic locus, okay, plays a role in the development of diabetes mellitus type 1. Including polymorphism in CTLA4 and PTPN22, as well as insulin gene variable number tandem repeats, VNTRs, are also present. Now, this has been simplified. This has been concised over here. I will discuss in details what they are. Okay, just have little bit of patience. Now, over here, unlike the type 1 diabetes mellitus, there is no linkage with the HLA or MHC. Okay. In fact, there is a linkage to diabetogenic and obesity associated genes like TCF7L2, FTO, and PAPARG or PAPARG genes. So mutations of these genes are more associated. In simple, just remember one thing. Type 1 diabetes mellitus is associated with development of autoimmunity, and type 2 diabetes mellitus is associated with obesity and fat deposition, central fat deposition and insulin resistance. Just remember these points. So the basic pathogenesis of type 1 diabetes mellitus occurs because of dysfunction in the T cell selection and regulation. So what happens, our T cells in our body, okay, which are basically the soldiers of our body, okay, so they are not trained properly. And because of this faulty training, they are recognizing the pancreatic islet cells as, as foreign, and therefore they are acting against them. So there is a breakdown of cell tolerance to the islet cell autoantigen. Just remember, there's a breakdown of cell tolerance. So what happens, our body T cells and antibodies, they are recognizing the islet cells, especially the beta cells, as foreign, and they are going and attacking them. This is what is the basic pathogenesis of type 1 diabetes mellitus. Okay, clear to everyone? Now, the pathogenesis of type 2 diabetes mellitus, if you see, it involves insulin resistance in the peripheral tissues. Very, very important. Insulin resistance plays a very important role in type 2 diabetes mellitus. So insulin resistance means that the peripheral tissues in our body, they are not responding to insulin. Okay, very important. Second thing is, because of insulin resistance, okay, initially the beta cells is going to increase the secretion of insulin, but later on they will get exhausted and there is a failure of compensation by the beta cells. Very, very important concept. I will speak about them in details. Also very important over here is that multiple obesity associated factors like increased amount of fatty acids in the circulation, increased inflammatory cytokines called as adipokines and the adipocytokines. All of these are contributing to insulin resistance. I will tell you in details about them, so don't worry about them. Morphology wise, if you see under the microscope, the pancreas, there will be presence of inflammation, that is insulinitis. So you will see a lot of lymphocytes present in case of type 1 diabetes mellitus under the microscope. The beta cell will be completely depleted, okay, and there will be islet cell atrophy that will be seen. Whereas in type 2 diabetes mellitus, no inflammation is present. You will see the deposition of amyloid in the islet, and there will be very mild beta cell depletion that will be seen. Now the frequency, if you see, the type 1 diabetes mellitus is less frequent, constituting 5 to 10% of all cases of diabetes, whereas the type 2 is more frequent, constituting 90 to 95% of all the cases. The more important or the more common complication that you see in type 1 diabetes mellitus is diabetic ketoacidosis, that is DKA. Whereas in the other form, it is hyperosmotic hyperosmolar state or syndrome, HHS, is more common in type 2. Now, the weight of diabetics in type 1 is normal or they have decreased weight, whereas in type 2, you have obese individuals. Okay, you have obese individuals in type 2. So remember, whatever be the case scenario, the ultimate summary of type 1 diabetes mellitus is that there is an autoimmune nature of pancreatic beta cell destruction. This is very important. Whereas in type 2 diabetes mellitus, there is insulin resistance plus beta cell dysfunction. There is an inadequate secretory response by the beta cells of the pancreas. Now, you must be thinking this point of difference that I have given you, many of these points you must know because you have already done the first year and you remember about these points. But very importantly, why have I given this type 1 and type 2 diabetes mellitus, especially over here, all these genetics and the pathogenesis point, that during the exam, you are not able to recollect many things. So this is very important chart that you can remember this chart and you can elaborate from this particular chart your answer. Okay, now we are going to first, before we go into the pathogenesis of diabetes mellitus, we are first going to understand and brush up our basic knowledge of glucose homeostasis. Because without glucose homeostasis knowledge and how the insulin secretion regulation is there in our body, you will not be able to understand the pathogenesis of diabetes mellitus. So these are all the basic concepts that we have already read about before. You all have read this in the first years. Okay. So basically what happens in the fasting condition, okay, there is a decreased blood glucose in our body. So our body is going to decrease the level of insulin and increase the level of glucagon. That is going to stimulate increased hepatic gluconeogenesis with breakdown of glycogen in the muscle, that is glycogenolysis will be there. And ultimately the end result is increased blood glucose level, that is there will be prevention of hypoglycemia. This is the normal glucose homeostasis in the fasting condition. After you have food, after meals, okay, there's an increased blood glucose level. So our body is going to increase the insulin and decrease the glucagon level. That is going to stimulate the glucose uptake by the tissues, especially the skeletal muscle. That is what is the action of insulin. So that is going to decrease the blood glucose level, preventing the hyperglycemia state. Yes, you don't have to write this in the exam. This is not the first year. Just you have to understand this concept. That's it. Regulation of insulin release. Now, how is the insulin release controlled over here? Let us try and understand. The beta cells of the pancreas, they first release a precursor protein, which will go in the Golgi apparatus. And from the Golgi apparatus, they are going to release the insulin. Along with the insulin, the C-peptide is also released, and they are basically stored in secretory granules within the beta cells. Now, the C-peptide that you see, very important MCQs are asked with regards to the C-peptide. It is a surrogate marker for beta cell function. So normally measuring insulin level becomes very expensive assay, or any hormone assay is very expensive, but measuring C-peptide is very easy. So the levels of C-peptide more or less indicates the level of insulin. So it becomes a surrogate marker for beta cell function. And this C-peptide levels can be used to differentiate between diabetes mellitus type 1 and 2 clinically. So the levels of C-peptides are reduced in case of diabetes mellitus type 1 because of reduced beta cell mass, whereas the levels of C-peptides are increased in diabetes mellitus type 2. Okay, so why it is increased? Because of insulin resistance and hyperinsulinemia, because of this particular reason this is happening. Okay, is this very clear to everyone?
Absolutely.
Now the most important, what is the most important stimulus for the secretion of insulin in our body? The answer will be glucose. So glucose is the most important stimulus for insulin secretion in our body. Now, very importantly, let us see now how the insulin release occurs. All this you have already know. Okay, all this you already know now. So basically, whenever the blood glucose level increases in our body, so what is going to happen? Okay, that blood glucose is going to go. What is this that we are looking at? We are looking at a pancreatic beta cell. So whenever the blood glucose levels will increase, they are going to go inside the pancreatic beta cell by means of a transporter called as GLUT2 transporter, which is an insulin independent transporter. It doesn't require insulin for its function. So this glucose now enters the pancreatic beta cell. Inside the pancreatic beta cell, they will undergo metabolism inside the mitochondria, and via the oxidative phosphorylation, the ATP will be generated. Once this ATP is generated, okay, this ATP is going to inactivate this ATP sensitive potassium channel. So this ATP that is formed because of this glucose is going to inactivate the potassium channel. And once the potassium channel is inactivated, it leads to membrane depolarization. That is, there will be excitation leading to an influx of calcium within the beta cells of the pancreas. Okay, this influx of calcium stimulates the release of insulin. Okay, now remember, insulin is released in two important steps. The first step, there is an immediate insulin release. So whatever insulin was there preformed in the preformed granules, they are released. That is the first phase of release. Now suppose the level of glucose still remains high. If there is a persistent stimulus, this is going to stimulate the active synthesis of insulin. That is, the second phase of insulin secretion is going to start. Is this point crystal clear to everyone? Yes. These are all the physiological aspect, and more or less this, again, this factor will be utilized when you will read pharmacology, when you will read the treatment of diabetes, again when you are going to read medicine, again this point will come into the picture. So this is the basic physiology that you are supposed to understand. Now here we have seen now how the body is reacting, okay, how the insulin secretion is being regulated and how the glucose homeostasis is being done. Now insulin is not the only thing in our body which is regulating the blood glucose level. There are some other aspects too. Then this becomes very, very important from your exam MCQ and Viva point of view. Okay, they ask lots of questions from you. Whenever you take the food, whenever there is an oral intake of the food, then two kind of incretins are released. Okay, the term is incretin. There is an excretion of substances which increase the insulin activity. Okay, insulin like effect is there. One of them is GIP. GIP stands for glucose dependent insulinotropic peptide. It is released from the K cells in the proximal small bowel. Another one is GLP-1. Another incretin is GLP-1 called as glucagon like peptide 1, which is secreted from the L cells in the distal ileum and the colon. Now both of them, okay, their level just increases just after you have food, and they have something which is called as an incretin effect. What is the incretin effect? They stimulate the increased insulin secretion from the beta cells of the pancreas. They reduce the glucagon secretion, and they also delay the gastric emptying, increasing the satiety. So all in all, what are they trying to do? They are trying to facilitate the activity of insulin. Okay, that is why, and so this becomes very, very important. So they play a very important role in glucose homeostasis as well. Is this very much clear to everyone? Now, once these incretins are released into the circulation, they are degraded by a group of enzymes called as dipeptidyl peptidase, DPPs. Okay, and especially out of all the DPPs, the DPP4 is very important for their degradation. So the level goes down after the release of these enzymes. So very important application, those who are reading pharmacology now, you will see that one group of drug is GLP-1 receptor agonist. Anything which is acting on the GLP-1 receptor, and it is mimicking the action of GLP-1 that will have insulin-like effect. Okay, they are used in the treatment of diabetes. Okay, and also anyone which is inhibiting the enzyme which are degrading the GLP and the GIP. Again, the inhibitors of these are also used in the treatment of diabetes mellitus type 2. Okay, so very, very important concept over here with the incretin effect that we are looking over here. Is this clear to everyone? Yes. Okay. Now, the insulin action and the insulin signaling pathways. We have to understand how the insulin is acting in our body. So first, very important point that we have to understand that insulin is the most potent anabolic hormone. Anabolic means they are building. Okay, so they are building. So they are body building. They are constructive in nature. They are making something. They are not breaking. They are making. So what is the effect of insulin in the adipose tissue? If you see, they will increase the glucose uptake. They will stimulate lipogenesis. That means deposition of fat. And they are going to decrease lipolysis. They will not allow the fat breakdown to occur. Okay. At the level of the striated muscles, again, they are going to increase the glucose uptake and they will convert the excess glucose into glycogen. And they are also going to increase the protein synthesis as well. Inside the liver, they will stimulate glycogen synthesis. They will increase the fat deposition, lipogenesis, but they are going to decrease gluconeogenesis. I hope everyone understands what gluconeogenesis is. That is the production of glucose from protein. That is the gluconeogenesis. That is because it involves the breakdown of protein. It will not allow. So it is going to cause fat deposition. It is going to cause glycogen deposition. It is going to cause protein synthesis. So all these are building blocks. Okay. So insulin upregulates the insulin dependent glucose transporter protein, that is GLUT4, in the skeletal muscles and adipose tissue. Thus, they are going to increase the glucose uptake into the adipose tissue as well as into the striated muscles by means of GLUT4 dependent protein transporter. Now, the glucose uptake in the brain, very important MCQ. Remember, in all parts of our body, the utilization of glucose is dependent on insulin except the brain. Now, brain, whether insulin be there or be not there, brain does not depend on insulin for glucose. So the glucose uptake by the brain is unconditional. And this is how nature has made it. It is insulin independent. Very important MCQ. Now, the basic role of insulin in our body is mitogenic. It is promoting growth and differentiation in our body. So this is the basic action of insulin. Okay. So if we look at this particular diagram, we are going to understand how the insulin is acting in our body. So this is the insulin, okay, which is acting, for example, in a peripheral tissue. Now over here, the insulin receptor, as you can see, it is a tetrameric protein. There are 2 alpha unit and there are 2 beta units. Now, once the insulin binds to this tetrameric unit, what is going to happen? It is going to cause phosphorylation of the beta subunit along with phosphorylation of the IRS and component, that is the insulin response substrate component. Now, that is going to activate the PI3K-AKT pathway. So those of you who are reading or who have already attended my class on neoplasia, you know there are 2 pathways of growth and differentiation. One is the PI3K-AKT pathway. Another one is the MAP kinase pathway, which we have already read. So insulin is basically stimulating this pathway of growth and differentiation, that is the PI3K-AKT pathway. So what are the effects? If you see, number one, they are going to cause this GLUT4 receptor. Okay, they are going to transport the GLUT4 receptor towards the cell surface. So by doing so, they are going to increase the glucose uptake. Yes, everyone will agree with me on this point. They are going to inhibit the phosphorylation of certain group of protein, that is the TSC1 and 2. By causing the phosphorylation, they are inhibiting these proteins and thus they are inhibiting the mTOR pathway. This leads to an increased protein synthesis. Again, they are going to cause the phosphorylation of the FOXO-XO. Ultimately, they are going to inhibit this FOXO-XO, leading to decreased glucose synthesis, and they are also going to inhibit this GSK3, leading to increased glycogen synthesis. Now, what is very important is now you don't have to remember these basic different proteins and transcription factors. But what you should remember, what are the subunits you should remember? You should remember which pathway it stimulates and what are the actions. Increase glucose uptake, increase protein synthesis, decrease glucose synthesis, and increase glycogen synthesis. This is what you should understand, the basic action of insulin on the target cells. So all these things you don't have to write in the exams usually, because these are points that just you need to understand so that you can understand the pathogenesis well. So any doubts you have with regards to the normal functioning of the insulin, release of insulin, how they are acting, what is the normal glucose homeostasis? Yes, everyone. Any doubts over here? If anyone has, asked me now, because now we are going to understand the pathogenesis of diabetes mellitus. Okay. So now we are going to understand about the pathogenesis of diabetes mellitus. Unfortunately, this is a part which is difficult to understand if you have not understood about autoimmunity. If you don't know the concept of tolerance, then it will be difficult for you to understand this topic. It is also the topic which is the most frequently asked topic. In any question in your answer, the pathogenesis of diabetes mellitus, write down the classification, then discuss the pathogenesis of diabetes mellitus. So you have to discuss both type 1 and type 2. And basically this comes for approximately 8 marks. Okay. So the pathogenesis, it comes for approximately 8 marks for both undergraduates, postgraduates. And this is the portion that is most difficult to understand, and it is left by everyone. So you have to pay a lot of attention over here to understand. And without having basic background on the concepts of autoimmunity and what is tolerance, it will be difficult for you to understand. So before I start this topic, I will just want to tell you few things. Now remember, in our body, okay, for example, this is the T lymphocyte, or for example, there is a B lymphocyte. Always remember, there is a group of genes. Okay, for example, there is the IR gene, there is the PTP-N22, there is the CTLA4. I'm not going to the details how these genes act, but remember one thing, that all this gene is responsible for developing tolerance. What is tolerance? I will tell you. So for example, in our body, this T lymphocyte and this B lymphocyte is produced in our body. Now, for example, to test whether this T lymphocyte and B lymphocyte are working properly, what our body is going to do, they are going to produce certain self-antigens, okay? And they will present it to the particular T and B cell. Now, normally, they should not recognize this antigen. In case they do not recognize this antigen, that means they are working normally. But if they recognize this antigen and if they go and destroy this antigen, that means they are self-reactive. So these self-reactive T and B lymphocytes, they will be eliminated. They will be eliminated by a process of negative selection. They are eliminated. This is how our body is developing tolerance to our self-antigens. Okay. Is this basic concept clear? Is this much is clear to everyone? Now, over here, just remember IR, PTP-N22 and CTLA4. These three group of genes are involved in this self-tolerance. I'm not going to details how and what, that is a separate topic of discussion, but for this much is enough. Now, first we will discuss the pathogenesis of type 1 diabetes mellitus. Very, very important. What did I tell you? What is the most important pathogenesis for type 1 diabetes mellitus? Yes, autoimmunity was discussed. Yes. So the immune cells over here, they will recognize and they will attack against the beta cell antigen. This is what is happening basically. Most commonly, they are developing in childhood. They manifest at puberty. Okay. But they can develop at any age. As I told you, they can develop even in late adulthood. So the term juvenile onset diabetes mellitus is no longer used. Now, there are two important factors over here, which is contributing to the pathogenesis of type 1 diabetes mellitus. One is your genetic susceptibility, another is your environmental factors. So coming to the first factor, that is the genetic susceptibility, it can be divided into two parts. Some of the genes are HLA or MHC associated. Some of them, they are non-HLA or non-MHC associated. So the most important locus of the HLA, locus means the address. Okay, which is the most common address or most commonly most common location, most common cluster of genes which are involved. So it is the HLA2 gene cluster present at the locus or the address 6p21. And this kind of gene cluster or whatever abnormalities are present in this gene cluster is contributing 50% susceptibility to develop type 1 diabetes. Now, how we are saying with so much surety, there are certain haplotypes or there are certain HLA regions which show an increased susceptibility to develop diabetes mellitus type 1. So 90 to 95%. Now, how we can prove, how we can say this? 90 to 95% of Caucasians. Who are Caucasians? The general white Americans, the Americans who are white. Okay, those are called as Caucasians. So 90 to 95% of Caucasians with type 1 diabetes mellitus, they had a HLA-DR3 or HLA-DR4 haplotype. So normally this haplotype is present in just 40% of the normal people. But 90 to 95% of Caucasians with type 1 diabetes mellitus were having HLA-DR3, DR4 haplotype. That means this particular haplotype has some association with the development of type 1 diabetes mellitus. Just this much is enough. You have to write this point. Similarly, 40 to 50% patients with type 1 diabetes mellitus, they have combined DR3, DR4 haplotype. That means they have both the haplotypes together. So 40 to 50% of patients with type 1 diabetes mellitus, they have combined, they have both DR3 and DR4 haplotype together. Now this combined haplotype is just present in 5% of the normal population. So this combined haplotype is again not normal. Similarly, very important, there are some individuals who are having either DR3 or they are having either DR4, either this or this. Along with that, they have a combined DQ8. So along with DR3, either DQ8 is present or along with DR4, DQ8 is present. So those individuals with such a haplotype, with either DR3 DQ8 or either DR4 DQ8 haplotype, they have the highest risk for development of diabetes mellitus type 1. This is a very important potential MCQ which will be asked in the exam. So this should be very, very crystal clear. Okay. The HLA or MHC associated genes. I am also telling you, tomorrow morning I will ask you, or maybe day after tomorrow, I will keep one MCQ from this portion. Let's see how many of you can answer this MCQ. So this was about the HLA or the MHC associated genes. Now there is the non-HLA or non-MHC associated genes, as I was telling you. Now, polymorphism means what? Polymorphism means variation in the normal, that is called as a polymorphism. For example, maximum individuals are having these base pairs. Okay. These kind of base pairs they are having normally. For example, they have AT, GC, AT again. For example, 90, all of us, we are having this as a normal base pair. But for example, in some individuals, okay, this GC will not be there, instead AT will be there. Okay, this is called as a polymorphism. When you have subtle changes in the entire base pair sequence, that is called as polymorphisms or changes. Now, sometimes certain changes present in the VNTR region. VNTR is a variable nucleotide tandem repeat sequence in the promoter region of
tandem repeat.
So basically, some subtle or very small changes present in the promoter region of insulin gene influence the expression of insulin by the thymic antigen presenting cells. Now, normally what happens, our thymic antigen presenting cells, they present the insulin to the T cell. Okay, they will present it to the T cell. And in that situation, when the T cell will see the insulin, then he will recognize, okay, insulin is our body part. Okay, so I should not act against insulin. But for example, if this is not there, if this insulin expression is not done by the APCs to the T cell, then the T cell will not know that this insulin is for our body. So this polymorphism in the VNTR region can affect the negative selection or elimination of the insulin reactive T cells. Understand? I know this is a little bit difficult to understand. I'm trying my best to make you understand what it is. Over here, just try to understand that normally our body is going to present the insulin with the help of antigen presenting cells to the T cells and the B cells. Okay, so normally this type of presentation is done so as to train the T cells that they should recognize the insulin as our body component only. But for example, if this if this presentation is not there, then our T cell will think that insulin is some foreign and they will act and destroy. This is one of the mechanism, polymorphism in the VNTR. Similarly, polymorphism in the CTLA4 and PTPN22 is also associated with autoimmunity. Now, I told you about this CTLA4 and PTP as well as IR gene over here only, that how they are basically acting. So I have already explained this point to you in detail. Yes, you don't have any doubts regarding that? Yes, I have already explained how the IR gene, PTPN22, CTLA4, how they are basically playing a role in central tolerance development, okay, in how to prevent autoimmunity. So any changes or mutations in these set of genes can lead to defective immune regulation, leading to autoimmunity. Okay, so these were all the genetic susceptibility factors. And mind it, this is the simplest way anyone will be able to make you understand this. So you cannot skip this part. Okay, this is what the examiner wants from you. Okay. Now, what are the environmental factors which are implicated in the development of type 1 diabetes mellitus? Viral infections, they can act as a trigger for this disease development, means they can speed up this process. Which virus? The Coxsackie B virus, mump virus, cytomegalovirus, rubella virus. Okay, so certain viral epitopes or antigens are very much similar to the islet cell antigens of the pancreas. So our body immune system, when they will develop a response against the epitopes, they will cross react with the islet cell antigens. And this concept is called as molecular mimicry. Everyone knows this concept. Also, sometimes there is a release of sequestered antigens or hidden antigens. So for example, some kind of infection for there. They cause some kind of inflammation in the pancreatic islet, leading to cell injury and release of the sequestered beta cell antigen. This, when released into the circulation, it stimulated autoreactive T cell formation against this beta cell. So there are two important concepts over here. One is molecular mimicry and release of the sequestered antigens. Both of them, because of the viral infections, can speed up the process of development of type 1 diabetes mellitus. So here are the two very important concepts. One is your genetic susceptibility, and another one, if you see, is our environmental factors, and both of them we have discussed in details now. Okay. Now, very important, as I told you, what is the mechanism of beta cell destruction? How are the beta cells destroyed in type 1 diabetes mellitus? This we have to understand. The clinical onset of beta cell destruction that is there, the clinical onset of type 1 diabetes, you will see, is very abrupt. Means, for example, today the patient is fine, tomorrow the patient will show signs, symptoms, and of all the complications of diabetic ketoacidosis. But remember, there is a gap period, there is a lag period between the initiation of the disease and the appearance of symptoms. Okay, because there is a progressive loss of insulin release. It is not like the insulin level on day 1 was 100 and now suddenly the insulin level in day 2 came down to 20. No, there is a gradual decrease in the insulin level from 100, 90, 70, 60, 50 like this, and ultimately it becomes 10 and 0, and then the patient have sign symptoms. Now, very important thing is hyperglycemia and ketosis. It occurs only after more than 90% of the beta cell destruction occur. So this is the reason that abruptly everything happens. Still 90% destruction doesn't happen, the sign symptom will not appear. Okay, clear to everyone? So this is very important. These are the stages of type 1 diabetes mellitus. What are these? These are the stages of diabetes mellitus type 1. They are having 3 important stages. Stage 1, stage 2, and stage 3. So this nomenclature is classically given in the latest edition of Robbins only. So if you see, as the time is passing, the individuals who are at risk for type 1 diabetes mellitus, they are going to develop. Now over here on the y-axis, they have shown the functional beta cell mass, and on the x-axis, they have shown the time. So in the initial period, they will develop all this, the pathogenesis. So there will be beta cell autoimmunity, but in that situation, there is a normoglycemia because some amount of beta cell is there, which maintains normal glucose level, and the patient is pre-symptomatic. In the stage 2, the patient's glucose level is impaired. It is not diabetic, it is impaired. Okay, beta cell autoimmunity is there, but the amount of beta cell mass now came down from this level to this level. Now, at this point, when there was 90% destruction, after that, in the stage 3, when there was 90% destruction was there, the patient developed signs, symptoms of diabetes along with the complication. So symptomatic type 1 diabetes mellitus is going to develop in the stage 3. Is this very clear regarding the stages of diabetes mellitus type 1? Yes? Okay.
Yes, sir.
So over here, what is the basic mechanism? The failure of self-tolerance in the T cells specific for the islet cell antigen occurs. How it occurs? Because of defective deletion of the self-reactive T cell. So whatever T cells they were acting against the islet cell antigens, they were not eliminated properly. Or there is a defect in the function of regulatory T cell, which you will recall, they suppress the immune response. or there is a resistance of the effector T cells to suppression by the regulatory T cells. So whatever be the mechanism, the basic thing is there's a failure of self-tolerance of the T cells. Our T cells, they do not tolerate the islet cell antigen. The self-tolerance is not there. So what happens, the T cells, especially the CD4 plus T cells, especially the T helper 1 subset. You know what are the subsets of T helper CD4? In the previous lecture we had seen T helper 1 is there, then T helper 2 is there, and T helper 17 is there. Out of that, the T helper 1 cell, they secrete certain cytokines like interferon gamma and TNF, which are going to injure the beta cells. They are going to cause harm to the beta cells. Secondly, we have the CD8 plus cytotoxic T cells, which can kill the beta cells directly, Okay, very important, clear to everyone? Okay. Now, antibodies are also present, and the role of autoantibodies are quite controversial. So antibodies against the islet cell antigens and against insulin is present. Now, which are the beta cell antigens against which this antibody is present? Very important. They are present against a beta cell enzyme, that is beta cell enzyme glutamic acid decarboxylase, called as GAD, and against another antigen, that is ICA 512, which is islet cell autoantigen 512. So antibodies are specifically formed against these two beta cell antigens. These are very important potential exam questions. Okay. So with this, we have completed in details about the pathogenesis of type 1 diabetes mellitus. Any one of you is having any kind of doubt regarding the pathogenesis of type 1 diabetes mellitus? Is it very clear? Okay. Now, after this, the more easy one and the interesting one, and also the more common one, we are going to understand the pathogenesis of type 2 diabetes mellitus. Now, the pathogenesis of type 2 diabetes mellitus is very complex, and there are multiple causes which are there. For example, there are genetic factors which are associated, certain environmental factors, and certain pro-inflammatory state, which is contributing towards the development of type 2 diabetes mellitus. So what are the genetic factors? Now, how we are saying that genetics is having a role? Now, no particular gene was seen to be affected, like in case of type 1 diabetes mellitus, but over here, when a twin, in case of a monozygotic twin, in between two, if one was having diabetes mellitus, other one was also having diabetes mellitus. So the concordance rate of development of diabetes was more than 90%, okay, in monozygotic twin. That means there is some genetic factor which is involved, that if one twin is involved, another is also involved. Okay. Now, first degree relatives, if you see, okay, of diabetes, if you see in your family, okay, if one brother is having diabetes mellitus or one cousin is having, the risk of development of diabetes mellitus becomes 5 to 10 folds more. Okay, more. Okay, so first degree relatives have 5 to 10% tenfold increased risk of diabetes mellitus. Now, genome-wide association studies shows the presence of more than 30 susceptibility gene locus, which is responsible for development of type 2 diabetes mellitus. Okay. Now, many of these susceptibility genes which were involved in the development of type 2 diabetes mellitus, they were also responsible for development of obesity and adipose tissue dysfunction. Now, very important, there was no autoimmune etiology cited in case of type 2 diabetes mellitus. Now, one very important gene which is now shown to show polymorphism, that polymorphism in TCF7L2 gene, they are associated with beta cell function and insulin secretion, and mutation and polymorphism in this particular gene provides greatest genetic risk, okay, greatest genetic risk for the development of type 2 diabetes mellitus. Coming to the environmental risk factor, which becomes very, very important in type 2 diabetes mellitus, the most important risk factor is obesity. Mainly which kind of obesity? Central or visceral obesity. Why we are saying 80% of people with type 2 diabetes mellitus, they have obesity. Now, obesity leads to increased insulin resistance. So if such obese individuals, they undergo weight loss, it was seen that the insulin resistance came down and glucose tolerance increased. The second most important risk factor for development of diabetes mellitus type 2 is sedentary lifestyle, means lack of exercise, which is very common in us today. Now, this risk factors independent of obesity is increasing the risk of type 2 diabetes mellitus. So if a person is thin and if he is just staying inside of home, he is also at a risk of development of type 2 diabetes mellitus. Now, there is a syndrome that is called as a metabolic syndrome, which is nothing but obesity plus hyperglycemia plus increased serum cholesterol and triglyceride levels plus hypertension. This together is called as metabolic syndrome. Now, one very important update in the 10th edition of Robbins is that, and everyone try to hear this, and especially those people who believe to wake up and to remain, awake at night and who sleep in the day, it is for you people. Sleep disorders, okay. For example, a person is having obstructive sleep apnea. For example, this is seen in obese individuals, okay. Plus those individuals in whom there is a circadian disruption. What is circadian disruption? That is a restriction of night sleep and daytime wakefulness. Those who are doing night duty, for example, they are just doing the night duty, then the sleep at night is not proper, or who are, daytime wakefulness is not there. Okay, he is sleeping in the day and he is waking at the night. For those individuals, this is affecting the insulin action and insulin secretion, and it is predisposing to the development of type 2 diabetes mellitus. This is a very, very recent update in the pathogenesis of type 2 diabetes mellitus. So please try to sleep at night and please try to wake up during the day. Okay, because if you alter this normal circadian rhythm, then you are at a risk of development of type 2 diabetes mellitus. Now, what are the metabolic defects in type 2 diabetes mellitus? Let us discuss the metabolic defects in type 2 diabetes mellitus. So there are two key abnormalities which are seen, okay, in type 2 diabetes mellitus. One is insulin resistance, the development of insulin resistance. And the second thing is a beta cell dysfunction. Now, this insulin resistance is nothing but it is a decreased response of the peripheral tissues, okay, to insulin. So decreased response of the peripheral tissues to insulin, especially the skeletal muscles, adipose tissues, and the liver to insulin. And what is the beta cell dysfunction? It is the inadequate insulin secretion in the face of insulin resistance and hyperglycemia. So what are the effects of insulin resistance? Remember, it is the most important factor causing its development is obesity. And effects of insulin resistance, once the body becomes, insulin resistance, once the body develops insulin resistance, there will be an increased gluconeogenesis in the liver that will lead to an increased blood sugar level, decrease in the glucose uptake and glycogen synthesis in skeletal muscles, again leading to an increased postprandial blood sugar level, and increased activity of lipoprotein lipase, which is going to break down the fat, leading to an excessive amount of free fatty acids in the circulation. So under the heading of insulin resistance only, we have to understand what is the role of obesity in development of insulin resistance. So the most important factor for development of insulin resistance is obesity. And which kind of obesity? Central obesity or abdominal fat. Okay, because abdominal fat, they have more tendency to break down as compared to peripheral fat. Okay, so let us see how obesity is playing a role. So the levels of free fatty acids. Now remember, the levels of free fatty acids in our body is inversely proportional to the insulin sensitivity. So more is the free fatty acids in the circulation, more will be the insulin resistance, because the insulin sensitivity is going to come down and vice versa. So excessive amount of free fatty acids in our circulation, because of an excessive breakdown of fat, they are going to saturate the fatty acid oxidation pathway. That is going to lead to an excessive amount of free fatty acids in the circulation, which is going to get converted into certain intermediates like diacylglycerol, phospholipids, pingolipids, and ceramides. And these are toxic and they are going to affect the normal insulin signaling, leading to a decreased insulin signaling, and they will also activate some inflammatory pathways, okay, in the pancreas. Ultimately, they will stimulate the phosphoenol pyruvate carboxykinase, leading to an excessive gluconeogenesis. Okay, ultimately, excessive amount of blood glucose level will be there. So increased free fatty acids, they are also deposited as triglycerides in the liver and the muscle tissue. So this is how excessive amount of how obesity is leading to insulin resistance, increasing the levels of glucose in the body, as we see in this particular pathway. Second thing is the adipokines. Now, normally the adipocytes, they are releasing certain adipose cytokines. These are called as adipokines. Now, there are some good adipokines like the leptin and adiponectin. They decrease the blood glucose level. We have read about them in obesity topic. And there are other group of adipokines like resistin and retinol binding protein 4, which increases the blood glucose level. So in obesity, what happens that there is a decreased amount of good adipokine, that is adiponectin, leading to insulin resistance. Okay. Third important role of obesity is inflammation. Now, what happens that pro-inflammatory cytokines are released in response to free fatty acids and glucose. This leads to insulin resistance and beta cell dysfunction. How does this happen? So, for example, increased free fatty acids in the circulation, they are taken up by the macrophages and the beta cells, and they stimulate the formation of inflammasome, which is going to activate interleukin-1 beta, leading to release of several cytokines, especially interleukin-1, which is going to directly promote insulin resistance in the peripheral tissues. So this is how obesity via inflammation is causing insulin resistance. And lastly, this liver steatosis that we see, this is very, very important. The latest edition in the 10th edition, this is not there in the previous edition. Increased free fatty acids in the circulation stimulates the fat accumulation in the hepatocyte, that is called as steatosis. And it leads to the development of what is called as non-alcoholic fatty liver disease to non-alcoholic steatohepatitis. This NAFLD stimulates the development of type 2 diabetes mellitus. So this was the first aspect of type 2 diabetes mellitus, that is how insulin resistance is being developed and what is the role of obesity in the development of insulin resistance, along with the effects of insulin resistance in our body. Now, the second important aspect of type 2 diabetes mellitus, as you will remember, was the beta cell dysfunction. Now, this beta cell dysfunction, okay, the requirement, now this is also a requirement for the development of overt diabetes. Just insulin resistance will not lead to development of diabetes. Now, remember, the beta cell function increases initially in the process of diabetes mellitus. And eventually what is going to happen? There will be exhaustion of their capacity to keep up with the demands of insulin resistance. So what is the mechanism of beta cell dysfunction? Let us see. The first thing is lipotoxicity. Lipotoxicity occurs because of excessive amount of free fatty acid, which compromises the beta cell function and decreases the insulin release and causes beta cell dysfunction. Now, excessive glucotoxicity because of increased blood glucose is also causing a compromise in beta cell function. Abnormal incretin effect leading to a decreased secretion of GLP-1 and GIP, which leads to a decreased insulin release, Amyloid deposition within the islets seen in more than 90% cases of diabetes mellitus, that is, you will see in the pancreatic islet the deposition of amyloid, and genetics, as we have already discussed how they are playing a role. Just a last diagram I want to show, and then I will conclude. So this is how, if you see, this is how the obesity is leading to insulin resistance. So obesity, the central adipocytes, is causing excessive free fatty acids via inflammation, and via adipokines, they are stimulating insulin resistance, as we have seen. So initially, what is going to happen? The pancreatic islet is going to cause, when there is an insulin resistance, there will be a hypertrophy. There's an increased secretion of insulin. So there's a normal to impaired glucose tolerance. So the blood glucose they try to maintain. But later on, okay, there will be exhaustion of the beta cells and there will be atrophy of the islets of pancreas. So there will be decreased insulin release and ultimately development of type 2 diabetes mellitus. So with this, we have completed the first part, the part 1 of diabetes mellitus. And tomorrow we are going to read the second part of diabetes mellitus. Any doubts anyone is having?